The topic for today is Obstetric Emergencies CBS session, and the speaker that we have here is Dr. Arun Raja Thangavel. He is a senior clinical fellow at Critical Care Guys and St. Thomas Hospital, UK. So you may take over.
Thanks, Fatma. Thanks for the kind introduction. It's all right. We have a good session ahead. So I've been taking classes on obstetric emergencies, and today we will be focusing on computer-based skills session, and this will be the first class in this topic. So myself, Arun, I work as a senior clinical fellow, as Fatima mentioned. I've done my European diploma in anesthesia and intensive care, and I passed the intensive care exam last year with the help of FOSS Academy, and it's my time to contribute back to the FOSS Academy, being a faculty. So first of all, congratulations to everyone again for pausing EDIC Part 1 and taking effort to appear for the EDIC Part 2, and you have all joined FOSS Academy, so you are in safe hands. And as far as I know, this is the only like coaching which is available for EDIC Part 2 in particular. There is no other class, even the EDIC preparation course, which is officially available from the ESICM, is nowhere close to this. You get a lot of exposure to similar exam type questions in FOSS Academy. So welcome you all to the class again. So objectives for today, we will get some more orientation towards how the EDIC Part 2 exam is going to be. That's the most critical part of passing the exam, understanding how the exam pattern is, how the questions are going to be. And for this session, we will have a CBS kind of questions. I have prepared like 10 questions in the obstetrics. In the CBS sessions, there can be like three kind of questions available. Either it can be a radiology or imaging kind of questions with some videos or static images appearing and a clinical scenario associated with that and couple of questions. Or it can be a big questions with multiple lab details, biochemistry, results available, and you need to tease out a diagnosis and a subsequent question. Or it can be a curve or a graph associated with the ICU. It can be anything. You have no idea from where they are giving the questions. So have an open mind when you appear for the CBS sessions. Although they are like simple sessions, the risk of failure in the exam is more with the CBS sessions actually rather than the CCS. CCS, we have a lot of clinical exposure, so somehow we can answer those questions. We have adequate time in our side. For CBS sessions, it's more like a quiz, rapid fire round. So it will be a total of 30 questions on the day of the exam, spread over 3 sessions. Each session will have like 10 questions. It can either be in a single module like radiology, all radiology and imaging in the single session, or it can be a mix and match of all the three types on the particular session. So within those 10 minutes, you need to answer 10 questions. That is the most challenging part. And the more time you waste on a single question, the less chances of completing all the questions and less chances of passing that session. So it's time critical. You need to be quick in reading the questions, coming up with a diagnosis, so you get chance to complete all the 10 questions within those 10 minutes. If you manage to answer most of the questions, you are almost nearly there with a pass. So that's the important tips on CBS sessions. So we will practice similar questions in our sessions and revise pertinent obstetric topics as and when needed. And I will try and modify your answers according to the expected examination standard. So some rules, let's keep it interactive and feel free to interrupt anytime and clear doubts. Interrupt me anytime, no issues at all. And try and answer as much as possible whenever you get a chance. Treat it like a mock exam. That's when you get most out of this course. And please, if possible at all, keep your videos on so I can see some faces to interact with rather than just seeing your names on the screen. We will try to give everyone an opportunity to answer like robin kind of questions. I am interested in knowing like who are the candidates who are like appearing for the exam this in couple of weeks, this May session. Can you unmute yourself or put a chat in the box so that we can prioritize you to practice your answering? Anyone appearing this May session?
Uh, all the aspirants are requested to switch on their cameras, and also if you can reply, do put it in the chat box.
Yeah, thanks. Thanks, Fatima. If possible, I know some of you must be working. It's not always possible to keep your mics and camera on. It's fine if even if you put in a chat or just or can unmute yourself and speak or keep your videos on. Otherwise, I will have to. Thanks, Christina. Fine. Anyone in particular appearing for the upcoming session? Am I audible, Fatima?
Yes, sir, you are audible to me.
Yeah. Okay, fine. I take it as a no for the upcoming session. So if most of you are appearing for the November session, I'm not prioritizing anyone.
Yes, I wrote in the chat box. I'm appearing for the next session.
Oh, sorry, I can't see chat. Yeah, some of you mentioned in chat. Now I'm getting so Mohammed. Give me a second. Right, so it's Mohammed Raga, Fatih, Elkhan, Anup, and Mustafa. So we will try to prioritize you guys who are going for the exams first. I will for like maybe ask you directly to answer. If that person is not available, maybe we can put it open to the others. Okay, everyone ready? Right. So the first question is like, I think I will go with Mohammad Raha for this question. If you can unmute yourself and come up with an answer. Can you see the question?
Yes, 32 years female, 3 weeks post delivery presents to induce breathlessness. She has cold breaths and PB 85 by 60. Blood gas shows metabolic acidosis and lactate of 8. What is the most likely illness? How will you manage?
Yeah, let me play
Please,
the video again. So this is the echocardiogram given to you. Sometimes they play such videos.
yes, this is postpartum cardiomyopathy.
Yeah, and will you manage?
In postpartum cardiomyopathy, this is post-delivery already. So just with supportive management, uh, we can add inotropes.
Yeah, and yeah, what kind of inotropes are the options? I mean, it's
Uh,
a general question. I'm sorry. Sometimes there can be specific
we have
questions
to
for
control
such
heart
questions.
rate.
Yeah.
We, we have to control fluid responsiveness first. If patient is fluid responsive, as MAP is already accepted, but patient has some metabolic acidosis.
Yeah. So that is end organ perfusion is not adequate.
Yes.
So we need to increase the cardiac output somehow. So we have
Uh,
few options. in the terms of inotropes, especially inodilators can be good in this scenario with some vasopressor support like dobutamine, milrinone, even levosimendan is being commonly used along with vasopressor support so that you maintain the perfusion as well. And yeah, advanced options like VA, ECMO,
We-
mechanical support devices if the patient really requires it. And Dr. Mohammed, can you explain the echocardiogram? What do you see, and why do you say it's peripartum cardiomyopathy based on this?
This left ventricular ejection fraction is low, and there's global hypokinesia with apical, like apical ballooning. Global hypokinesia, this is left ventricle.
Yeah, we cannot really see the apex here. So it would be helpful
Yeah.
if you, in your answering, frame it like it's a parasternal long axis view. We are not expected to be like experts in echocardiography, but at least the basic views and uh, our diagnosis based on the echo. If you can add it to the diagnosis, that would be helpful. Maybe carries a point, we don't know. Apart from peripartum cardiomyopathy diagnosis, maybe they expect with severe LV dysfunction. Uh, so just whatever you get like focused diagnosis, you can put it out in the exam so that you don't lose out on marks. One more question I have, like it can be open to the audience. What do you think of the role of bromocriptine in the diagnosis of peripartum cardiomyopathy? Do you use it? Have
Beneficial
you used
because I
any?
think prolactin has a main role in this issue. So prolactin is used as one of lines of treatment.
Sorry, I didn't hear your answer properly, doctor.
Prolactin is accused as the major cause for peripartum cardiomyopathy, and bromocriptine is used to control such a case.
Hmm. Yeah, there is some controversy in between the boards across the countries. Like American board is not keen on using bromocriptine. They don't suggest to use it, but Europeans definitely favor the use of bromocriptine. Especially one thing to note is if you are using bromocriptine, you should be using along with anticoagulation. Definitely with such severe LV function or dysfunction, you will be using anticoagulation anyway. But especially with bromocriptine use, it is advised to use along with anticoagulation. Thank you, Dr. Mohammed. I think next question we can put it to Fatih if you're available, if you don't mind
Yes,
taking the
yes.
question. Yes, go ahead, Fatih.
Okay, 20-year-old woman at 30 weeks gestation presents with sudden onset of severe headache, blurred vision, and hypertension. She has positive proteinuria. What is the most likely diagnosis and what is the first line treatment to prevent complications? Uh, of course, the patient has the symptoms of preeclampsia, and she's high risk to develop eclampsia as well, or to progress into eclampsia if not properly managed. The CT brain, which is shows a little bit of, although there is still gray matter and white matter differentiation, but might be there is features of mild brain edema. So our first line now to prevent complications is to control the blood pressure, to put the hemodynamic support and put the patient in a monitored area like a high dependency unit or ICU. The mainstay to prevent the progression to eclampsia and to control blood pressure in this context would be magnesium IV, by giving 2 to 4 grams loading and then 1 to 2 gram IV per hour, with monitoring of the renal functions, urine output, and knee clonus, to prevent the symptoms of magnesium toxicity or hypermagnesemia. In addition to this, of course, the patient would need full investigations, including CBC, complete blood count, urea and electrolytes, liver function test, coagulation assay, including BT, INR, and ultrasound abdomen to check the condition of the liver, especially condition of the kidneys, and fetal ultrasound as well to check the viability of the fetus, and if possible, if the symptoms are not well controlled or progressing, then we would think about early delivery. Early delivery, and of course, we have to use that what's called fetal monitoring or topography, CMG or CTG.
I'm going to stop you there, Dr. Fatih. That's a comprehensive answer. Excellent answer. Thank you so much. Yeah, for CBS sections, you don't need to be so elaborate, but if you may start with giving specific answers, if the examiner is looking for more answers, like if they are giving you a prompt, is there anything else you want to add? Then go ahead, give as much as possible so that you get the mark. But if they are happy with the initial answer, they will just move on to the next question just to save time. Yeah, you need to be precise in your answer so that you save time in your answering as well. So just be mindful of that. For the, for the purpose of this class, you are free to answer, take your time. But with the exams coming up in mind, I'm just putting you to be mindful of the
Thank
time
you.
you are taking up. And
Thank you very much.
what are the other features of cerebral edema in this CT? You did mention like gray-white differentiation. And what are the other features we say?
Sylvan Fisher is not obviously Sylvan Fisher, although we don't have all the cuts, but obviously I cannot see the Sylvan Fisher.
Exactly. The
Ventricles
effacement of the
also
sulci and gyri. Yeah.
Compression of the lateral ventricles is very important.
Yes, that's another thing, isn't it? Whether the lateral ventricles are compressed. Unfortunately, they don't give you like all the cuts in the CT images. Whatever the exam questions they gave for me, they just put it like a single cut, and we had to make a diagnosis. Sometimes it's not clear, unfortunately, but this is how the exam is. So we need to be prepared for just answering with a single cut as well. And yeah, as we discussed, lateral ventricles, compression, effacement of sulci and gyri, and white matter differentiation. And in such scenario, like I agree with the general management. What is the role of like mannitol or hypertonic saline if the patient really has cerebral edema, apart from management with magnesium? What do you think evidence says, or what is the practice?
The evidences are very poor regarding this issue, but usually when the patient develops signs of severe pre-herniation or lateral signs of lateralization, at this point it's life-saving measure. But usually we don't tend to use those measurements in pregnant ladies to avoid any kind of volume depletion, which might happen with this kind of with these agents, especially mannitol and hypertonic saline.
I totally agree with you that, Dr. Fatih. Mannitol, especially volume depletion, and even in the fetus, it can cause hypovolemia. That's the concern with mannitol. And hypertonic saline, we have very limited evidence of use in pregnancy. So that's the concern with that in case you are asked in any questions. So I think we can put these questions to Anup.
Yes.
Go ahead, Anup.
Yeah, it's a 30-year-old woman at 26 weeks of gestation, present with acute shortness of breath, pleuritic chest pain, and tachycardia. BP 160. She has a history of DVT. What is the diagnosis and what is the next step? This is a CT thorax of that patient showing irregular filling defect in the both main pulmonary arteries. Might be a pulmonary embolism. And next step will be, as the BP is normal in range, I will go for a anticoagulation.
Yeah, that's pretty much crystal clear, isn't it? Thanks so much for Anup. I think you will get full
Yes, sir.
marks if you answer like this.
Thanks,
So
sir.
that's all it's needed. Just be precise. What is the next step? And if the examiner is still looking for some answer, then maybe you are missing out on something. Try and add some more thing. But if you're not, if you're stuck, if you're not getting the diagnosis right, just say pass. You can
Okay,
come
sir.
back to the same question if there is time in the end of 10 minutes. The examiner can come back to the question, or you can ask for, can we go back to the exam question number 3? So if you are stuck anywhere, just go to the next question, and so that you save time there as well. So as Anup clearly mentioned, pulmonary embolism is the diagnosis and anticoagulation choice. And one particular question I want to add is, which anticoagulation or like drugs and contraindicated in pregnancy?
Warfarin.
Warfarin.
Warfarin and anything else? Can we use DOACs like Epixabans, Doxaban? Can it be used in pregnancy?
No
What is
evidence
the
yet about usage.
No, sir.
No evidence
We
about
can
use.
we
Yeah.
can use danaperoid, sir.
Tenaparoid, I'm not sure, but DOACs generally are contraindicated as well. So, which is not usually discussed, but I found it interesting when I was reading this topic. Okay, so who can answer next? Can we go to Mustafa? Are you there, Mustafa? Or Dr. Anika?
Dr. Elkhan, you mean, or?
I'm happy for you to answer, Elkan.
I can answer.
Sure, go for it.
A 35-year-old woman postpartum, 12 hours after delivery, complains of severe pelvic pain and inability to avoid. On examination, she has a tender, boggy uterus. She is febrile and started to bleed per vagina. What's the molecular diagnosis? And what is the next step in the management? So by ultrasonography, it seems that she has bled. That's called postpartum hemorrhage.
Yeah.
The uterus seems to be full of the blood.
Mhm.
And for postpartum hemorrhage, firstly, we need to monitor the patient, to call for gynecological help, and to start ABA or breath and circulation, to monitor the hemodynamics, to request for blood and for blood typing, cross matching, all these things. Because this patient might need the operation and exploration again. And I will start straight away from the beginning for tranexamic acid, because by women's study, this is the first thing we have to do. That's the all.
And
I think massage, utile massage, and oxytocin first. We have to start, and prostaglandins, intravaginal.
okay, I didn't quite
As I said,
understand your question. Sorry. Can you put it in a different way or repeat it again, Dr. Mohammed?
يعني apart from hemodynamic optimization, we have
Yeah.
to start by manual utile massage and
Okay. Yeah. Yeah.
oxytocin and prostaglandin intravaginal. This I think we can start till OB people see and make a يعني ultrasound already done, and activate a massive transfusion protocol if patient is already shocked because it's not cleared.
Yeah, I agree with you. And in it's not fair to, I mean, asking us to interpret obstetric ultrasound, but we should, since it's an obstetric emergency topic, I had to give it, and it's an emergency topic, I had to give you some ultrasound images. But you never know, you might be asked in the exam. And I didn't quite get the answer clearly from the ultrasound. I agree with the postpartum hemorrhage part and its management. From the ultrasound image, this is ultrasound of the uterus showing some content.
uterus يا توني
Still not yet.
Retain the placenta, I
uterus.
presume. Retain the placenta?
Yeah, exactly. So it's retained product of conception. So that's the exact diagnosis I wanted, but we were close there, right? So, and with
Okay.
postpartum hemorrhage, of course. So we need to evacuate the products immediately. And I agree with the rest of the management. We need some uretonics, dose and carboplast based on whatever patient has already received, and carry on with the PPH management. Okay. You guys happy with the ultrasound image? I had some more like details of the retained products of consumption. So based on how vascular the inside part of the endometrial content looks, it determines the severity. The more vascular, more severe the bleeding is going to be, and the content of retained products are there. So the type 3, as you can see, is having like much more vascularity within the uterine wall, whereas the type type 0 is having very less activity. So just to keep in mind, in case you don't have to review these images again, just have a look at this and go to the exam. Okay, who can go next? I think we will have to. Anyone? Any volunteers for this question?
I can
Yes.
take it, okay?
Yeah.
Who you want to, me or
Who else has
okay?
wanted to answer? Arpit or Fatma? Oh, sorry, Fatma is the coordinator. I think Arpit.
40 years old woman at 30 weeks gestation present with right upper quadrant pain, nausea, hematuria, and elevated liver enzymes ALT 500, platelet count 50. She has hypertension 160. Platelet count is trending down. Question: what is the diagnosis and what is the definitive management? It looks like Helm syndrome, and this is hepatic hematoma, like hepatic rupture.
Bleeding, bleeding around the liver.
It's definitely a hematoma. Yeah.
Subcapsular.
So this is the answer I had. Like HELP syndrome, absolutely, it's so clear. And it's in this picture, precisely it says subcapsular liver hematoma. I understand it. As long as we say hematoma, I think it's fair. And management, as you mentioned, in this patient in particular, the platelet count is low and it's trending down. So we will focus on treating that and correcting coagulopathy, conservative management. Any specific, if the hematoma is rapidly expanding, any specific management for that?
Laparotomy.
Laparotomy.
Interventional radiology.
Interventional
Emergency
radiology, embolization.
Yeah, we will refer to the surgeons first, then we will involve the interventional radiology anyway, right?
Control blood pressure and platelet count, and after this intervention radiology will be.
Yeah, I agree with that. Interventional radiology. Even the surgeons will be more in favor of interventional radiology, and if they have a target based on the imaging, if they can embolize, that will be the best thing for the patient in this situation. Right?
In the context that the patient is pregnant, what is the meaning about interventional radiology with all the radiation for the baby?
Right, that's an interesting point, but it will be a MDT discussion. In such controversial scenarios, we always take help from the team members, surgical colleagues, and interventional radiology, and involve the patient as well. We should give them the option of which one is the best for them, put it out to the patient, and ask for consent, right? That's what we do in practice. That's a good point you made, Christina, there. Yeah. Fine. Happy? It's
Also, we have to look for abdominal compartment syndrome in this.
Abdominal compartment syndrome, yeah, could be related complication, but yeah, for this question may not be related. But yeah, that's good thing to keep in mind.
30 weeks already radiology up to radiology exposure is safe after how many weeks of gestation?
With regards to radiological exposure question, yeah, it's a big question in obstetrics itself. With the period of teratogenicity is basically in the initial few weeks of embryo development, right? After that, the embryological teratogenic effect of radiological exposure is less, but per se, we don't want the mom to get exposed because of the increased risk of breast cancer. That's when the exposure to CT related, even with the CTPA, we are worried more about the mom getting increased risk of breast cancer. That's why we try and avoid in pregnancy the radiological exposure. Yeah, that's a good point and to bring up. Shall we move to the next question? Christina was kind enough to keep her video on, so let's give her a chance to answer the next question.
Okay. A 29 years old woman at 36 weeks gestation present with sudden collapse after amniocentesis. Question: what is the most likely diagnosis and what is the immediate management? I think that is a how do you say in English? Acute after the amniocentesis, when the patient present an embolic amniotic thrombo, and
Yeah,
you can
embolism.
see, yes, and you can see in the right ventricular how it's pushing the wall to the left ventricular. I think the immediate intubate the patient, support air B, C, D, and that is sometimes I think that you need to use inotropes and maybe deliver the no, it's, oh yes, cesarean section, and support.
Yeah, that's an excellent answer, Christian. Thanks for taking that. Yeah. So amniotic embolism can happen even after amniocentesis, not necessarily
Yes.
after delivery. So that's an excellent answer there. And it's a wonderful echo, which I did in a different patient, but I used it for this scenario, which showing acute RV dilatation and septal being almost D-shaped throughout the cycle. So that's a massive pressure overload and sudden kind of pulmonary hypertension crisis. So I would be surprised if the patient is still having a circulation going. Maybe she got arrested. She might need CPR and the rest, whatever Christina mentioned, like focusing on the supportive management. And if you were in the last class when we discussed amniotic embolism case, we should be focusing on uterine displacement during the resuscitation and think about perimortem, C-section, and even ECMO if it's available. Thanks, Christina. Who is the next one to go? Any volunteers?
What's the question?
Right. Here we go. Feel free to unmute and come up with the answer if you are sure, even if you're not.
A 25-week-old woman at 28 weeks of gestation presents with vaginal bleeding and abdominal pain, no history of trauma. What is the diagnosis? Major risks. So we can see that the placenta is quite near the cervix. So this might be placenta previa, and at this covering the os, so it is central placenta previa, and the trauma less atraumatic bleeding is because of that only.
Yeah, it's quite straightforward if you know the diagnosis, right? Yeah, you're absolutely correct. Yeah, it's absolute contraindication for vaginal delivery, even attempting to deliver vaginally. And there are very few causes of antenatal significant hemorrhage, and placenta previa is one among them. And yeah, we don't see these ultrasounds regularly, but you never know, you might be asked in the exam, so let's be prepared for it. And everyone understand the anatomy. This is the head, and as label, I put it out to just help everyone get the orientation with the labels on. So this is a cervical canal, and we can see the placenta in between the fetal head and the cervix. So it's clear central placenta previa. Yes, Swati. You okay? Fine.
Hello?
Yeah. Yeah. Go for it.
I cannot see the me.
You cannot see the placenta?
No, placenta. Yes, I can see the placenta previous. Okay, thank you. No, it's okay. Thank you.
Yeah. Fine. So, thanks, Pika. Well done. This is kind of buzzer round now. Whoever goes for it gets the answer.
Oh, this is necrotizing fasciitis.
Excellent. And can you describe the image?
There are some air bubbles under the skin and in the soft tissues, and there's some inflammation as well. So this is clear-cut necrotizing fasciitis, and it needs an emergency debridement because it's quite it's surgical emergency and the medical as well. So it should be debrided immediately, cleaned, and proper antibiotics are to be started, including clindamycin.
Excellent.
And L-Renic, I think L-Renic is called the scoring system, and it could be assessed by L-Renic to see how the severity of the disease itself, how it's progressing, or what's the chance of the patient to get rid of this.
Excellent, Dr. Elkan. You get a bonus point for your excellent answer. What is the role of IVIG here? Do you use IVIG?
Well, it's used. It's used. Not in all the schools, I think, but it's used.
Yeah, definitely. If you are having a toxic shock syndrome, like
yes,
picture.
Exactly. Yes.
And what are the common organisms which can cause this?
It is common organisms. It could be polymicrobial. It could be, because there are 4 types. It could be fungal, polymicrobial. It could be streptococcal infection or staphylococcal. And sometimes even in immunocompromised people, it could be an opportunistic infection as well. But the common organisms are usually Clostridium perfringens, streptococcal infection, all these things, staphylococcal infection.
Streptococcal, mainly group A streptococcus. That's when it presents like a toxic shock, and that's why we add clindamycin as well, which has an antitoxin. Thank you, Elkan. Thank you for the excellent answer.
Okay.
We have just one more question after this. So this is a short session. Who wants to go next? Try practicing. This is the place you can practice. Don't be worried about being wrong. In the exam, of course, you need to be speaking for like 30 minutes in a session, and you need more stamina and energy for the exam. Any takers? I can explain the ultrasound a bit. So this is a fetal head, and here we have the placenta, and these marking are the diagnosis in question. So what's happening here? One more clue I can give is we discussed about causes. Excellent, Kavita. Yeah, that's what I was coming to. And yeah, why do you say it's abruptio placenta?
There is a blood between the myometrium and
behind the placenta and below the myometrium, you see a collection of like, could be anything, but we think it's hematoma, and that's why the placenta. It's more of a clinical diagnosis, right? There are very few causes of antepartum hemorrhage. 2 major differential. One is abruptio placenta, and other is placenta previa, which is most concerning if the patient presents with PV bleed. So this is the other diagnosis. And what's the management?
Immediate resuscitation and cesarean emergency C-section and blood and blood product transfusion.
Yeah, correct. The coagulopathy. So this question, we all had to like think for a while of what's happening in the image. We didn't have an idea what's going on. So these are like good examples where you just skip the question, come back to it later when you have time, because there will be few easy questions. You don't want to miss out on those easy ones. Yeah. So coming to the last one. This is an interesting one.
This is Press syndrome.
Posterior visual subluxation.
Yes.
Press syndrome.
Press syndrome, yes.
Press, and what's the complete diagnosis? Press, I agree with the radiology.
Okay.
With preeclampsia.
Eclampsia.
Yeah.
Caesar, eclampsia. There's Caesar eclampsia.
I think that is eclampsia as well.
Yes, well done, everyone. So that is clearly eclampsia. She has clearly progressed from preeclampsia to eclampsia, and MRI is showing press. So what you can see in the MRI, if anyone can describe the findings in the MRI, why do you say it's press?
Hyperintensity in the
bilateral
posterior.
hyperintensity in the posterior area, most probably in the occipital area,
Yes,
hyperintensity area, bilateral.
Yeah,
and it's
The
reversible.
posterior
That's
circulation.
fine. And we all know the anticonvulsant of choice. And okay. So further questions I had for you is, what are the contraindications of magnesium sulfate? There are very few contraindications. Even in a
Acute kidney
pregnant.
injury.
myasthenia gravis.
Excellent. Myasthenia gravis accepted.
Acute kidney injury.
It's not really a contraindication. We should be more careful with the dosing. I agree. We need to be doing the monitoring and be worried
Maybe
about
severe hypocalcemia can also be a contraindication because they are.
Excellent, Dr. Alkan. Yeah, that's absolutely. And one more thing is like severe conduction blockade, AV blockade, where you'll be worried about using magnesium. So these are very few contraindications of magnesium. Otherwise, we love using magnesium, right? We use it for everything. Fine. And
Sir, can you
Why
repeat
severe hypocalcemia is
contraindication?
sorry? Why severe hypocalcemia is contraindication?
magnesium is kind of physiological antagonist of calcium. So it's going to aggravate the hypocalcemia and its symptom if you are giving in severe hypocalcemia. So the contraindications are myasthenia gravis, severe hypocalcemia, and high degree conduction block.
Okay, thank you.
Yeah. And yeah, the press, this picture is quite like you can recognize it as press when you see it because it's more in the parieto-occipital region and it's symmetrical, but it can be of various degrees, and all these are like findings of press. It can be in different territory, MCA or even ACA, even just limiting to the like midbrain areas and brainstem areas. So it can present in a different way, but most typical is in the parietal occipital region. And is there any MRI experts available here if they can explain which like weighted image in particular is this? Which image do we see the press change at best?
T2, I
Diffusion.
presume. T2.
Flare.
Who is
T2
that?
diffusion.
Came up with flare. That's an excellent answer. Yeah.
Flare.
Can you explain what's flare?
When you remove.
Yeah, it's interesting to just know what's why we call it flare. So basically in T2, CSF is like bright, right? CSF is supposed to be like appearing white.
Mhm.
Flare is a T2 image where there is fluid restriction.
Removing.
So the CSF appears black. So it helps in bringing out the white matter structure changes. So we can, especially in press, we can see the subcortical white matter, which is getting the problem. And the pathology is like vasogenic edema or cytotoxic edema, which is best seen with flare sequence. So this is uh, this is a T2 flare sequence. If you check all the images for like MRI for press, it will be T2 flare where you can pick up. Radiologist pen maybe can pick up in other images as well, but it's best seen as a like bright structures in T2 flare. Yeah, that's all I have for this session. Any doubts you have, especially those going for the exam?
It was excellent. Thank you so much.
Yeah, appreciate it. So
Thank you so much.
there will
Please
be
can go
subsequent
again to necrotizing fasciitis again.
necrotizing fasciitis. Yeah.
Okay, the answer. Okay, thank you.
Happy? Yeah, we
Where
can
is the
easily.
gas?
Okay, yes, happy,
Where is
thank
the
you.
gas? Sorry, I cannot see the gas.
gas is where the red asterisk is. Like these are the gas bits. We don't usually, whatever is like pure black, it's like gas in the CT. So
Do you think purpura sepsis would be a good answer? If we cannot see the gas, we can say purpura sepsis, because obviously this
you
is
can
only
definitely say that, but with profound shock and such CT image, which is like specifically showing gas shadows in the subcutaneous tissue, I think necrotizing fasciitis will be a better answer. Puerperal sepsis is a broad terminology, and necrotizing fasciitis is a more definite diagnosis here. Yeah,
excellent.
it's not wrong to say puerperal sepsis, but if you can give a
Because
better
the gas
answer-
actually the gas is the gas loculi is a little bit difficult to see, especially in the context of the exam and this kind of image.
It is,
And
isn't it?
the first thing I can see now is the hyperdense tissue-like fluid structure, which I can see inside the uterus. But that's what the first thing, which bulky uterus and looks like an infectious tissue, infected tissue. That's what really attracted my attention or drew my attention from the first instance. But
Yeah. I totally understand your anxiety, but
I think
yeah,
this
we
is
need to get
bladder, not
used to
uterus.
seeing air in the wrong places, especially with abdominal CT, because you can get a lot of questions based on just presence of air in the wrong place, like mesenteric ischemia or pneumobilia. So these are like it's easy to miss, but it clinches you the diagnosis. And they will just put one image like this as a static image. You don't have the option to scroll through the images. So it can be difficult for the exam, but that's how we get the mark. We need to be
Sir,
responsible.
is this bladder or uterus? This is bladder or uterus?
I think it is
bladder,
bladder,
most probably,
but I
bladder.
can't see the uterus. It's interesting.
But that's what I thought
So,
about. That they're not going to show us the uterus. Maybe they're going sorry the bladder, maybe the uterus. But if the uterus looks like this, something wrong with it. So, but
Yeah, I didn't give much
so,
attention to what's underneath, but
because if it's still bulky like this, it would be that would
I mean,
something wrong with it.
it still could be
Doctor,
uterus. I don't know. I'm
Dr.
not an
Fatih,
expert here, but
sir,
yeah.
what is
necrotizing
the
fasciitis in
role
exam
of
is always confusing. Yes, necrotizing fasciitis is always confusing, like the emphysematous intestinalis or something. Those airbags is it's not clear actually, and some always missing. Yeah.
Maybe
Yeah.
I think yes, maybe no.
sir,
Anyway,
so what is the role of anticonvulsants if the seizure is refractory to magnesium, sir?
Definitely, then we have to follow the protocol like benzodiazepines.
So
If we
is
have
there any
IV
cutoff,
access.
sir? Is there any cutoff if we are keeping the magnesium within 4 to 7 milliequivalent per liter, even though the patient is having seizures, we can go through that.
There is, I don't think there is any cutoff like after this point you go for the other agents. If you
Okay.
think the magnesium is not, it's in the range, but the patient is still seizing, we need to be
Okay.
worried about other causes of seizures like intracranial hemorrhage. The patient might need a urgent repeat CT head or first imaging in the first instance and
Okay, sir.
treat as per the routine seizure protocol. You don't wait
Yeah,
for,
okay, sir. Okay.
yeah.
I want, yes.
So then we can go for a EEG monitoring. So
Yeah, if the patient is clinically seizing, EEG is not
okay,
going to
okay,
add value in the immediate management. But
okay,
if the patient is not waking up, especially like a PRES patient, where the patient
okay,
is not waking up, there can be subclinical seizure activity where EEG has a role.
okay, sir. Okay. Then we will achieve burst suppression, right, sir?
Burst suppression, if it's status epilepticus,
Okay.
burst suppression
That's
is
what my
a
question, sir.
controversial topic. Whether it has any value in the clinical management in the long term, it's very unclear.
Okay,
It's
okay,
still
sir.
a debatable topic. We don't, we are not, we are kind of moving away from burst suppression
Okay,
in
sir. Okay, sir.
cases we have seen. So it's not the first thing which we do, unless it's
Yeah.
like super refractory status epilepticus, which is not responding to any treatment. Then maybe
Yeah.
we
Okay,
can
sir.
consider burst suppression.
Okay, sir. Thank you, sir.
I'd like to ask about the management of preeclampsia. It's mentioned that we will give an infusion of magnesium sulfate. Because generally it's accepted that magnesium sulfate we start when patient develops seizures. For the management of hypertension, usually we use labetalol infusion, nicardipine, nifedipine, or hydralazine, methyl-dopa, this kind of medications.
Yes.
Could it be mentioned for the management of, the magnesium sulfate, could it be mentioned for the management of blood pressure in preeclampsia, or we have to put a clear-cut border that it should be started when patient develops seizures?
I think, I agree where your question is coming from. To answer your question, I would say like it's not wrong to mention magnesium even as a blood pressure control. It does drop your blood pressure. So even in severe preeclampsia patient, we do start magnesium sometimes. So I don't think it's wrong to say in like antihypertension management. You can mention it. It's nothing wrong in mentioning that. Yeah. There is no negative marking in EDIC exam. That's the best part of it. So you can answer even if you're like not very sure, 50-50 answers, you can just put it out. If there is no negative marking you're getting. So do answer rather than missing out on it. If there is a point for that, it's better to answer it. And even if you go wrong, there is no negative point. If you get what I mean. Yeah. Any other questions?
Thank you so much, Arun. Very excellent session as usual from you. Thank you so much.
Thank you, sir.
Thank you,
Thank you so
Fatih.
much.
All the best for those appearing for the exam. Hope you all clear.
Thank you so much,
Thank
Arun.
you, sir. Thank you, sir.
Wish us good
Thank you so
luck. Thank you. Bye.
Thank you very much.
Thank you. See you guys. Bye.
Thank you, students. Thank you, sir. The next session will be soon. Till then, good night.